session is interactive, and you're going to stop.
We must be, of course, yeah. We'll keep it interactive. And this is my first time in this room.
Yeah.
Arik was here like 10 times, 15 times, how many times?
Many.
And Chaim maybe 30 times, I don't know.
30, I wouldn't. I think it's the fourth year, so maybe.
So we have prepared several things to
see.
show and discuss in the room today. And we debated what to present to you, but we're going to talk first about patients with small anatomy and small annuli and how to optimize outcomes and what to do with these patients. I came from India a couple of days ago, and small is different than our small, and if I go to Ole de Bakker in Denmark, maybe their small is like our gigantic valves. I'm not sure what is small. So first, what is a small valve? How is it the practice in Greece? Like, what is small? What is considered small here in your state?
Well, I think this the definition less than 400 millimeters. It's applicable to Greece. It's when you have, I think, to 23. It's not a small valve. And maybe Dr. Giakas.
It will depend on the body size of patients.
A different opinion, or I see Dr. Darladimas. For the Greek population, the old, petite ladies, 23 is okay. I think it's borderline, but it's okay. So that's why we have the unfortunate event that we have a lot of trifectas 21 and 19 and mitral flows 19, because all these are petite ladies that they were being treated surgically with small valves.
So I assume that it's like East Mediterranean, it's closer, it's less than in the US and Western Europe, but there are also tall people like...
Dr. Mariano, you have the same opinion, or still? Okay.
Obviously, we should correct to the size of the body of the patient in some way. But it's clear that small anatomy is a problem, right? It's a problem because these patients do not get as good hemodynamic result than patients with bigger anatomy. In general, when we do their valves, we can say that they're going to last probably not as long as people with larger valves. We can say that when they need a procedure, when they degenerate, their valve procedure, the TAVI procedure or surgical procedure would be more complex. And the result of the second procedure will not be as good. So many issues related to prosthesis-patient mismatch, to the issue of having too small device for the body size of that patient. And it's complex what to do. You have a patient with small anatomy, and that patient is not very small, it's like intermediate, maybe large size. What would you do? What would you do, Arik, what would you do in a patient that has, let's say, 3 feet, a lady with a annulus of area 300, perimeter 54? What would you do?
I think that the decision making is so multifactorial. So I can't refer to an 88 years old lady who has a 350 as I will refer to a 72-year-old male who is fully active and doing sport, etc. So I cannot answer this just as a yes or no. But yes, I think that in patients that the orifice area, effective orifice area is truly important, and PPM is truly important. And in all those studies that we're writing about PPM, it's a huge aquarium. And PPM of mild PPM, namely less than or like 0.85 per definition, has got nothing to the prognosis and quality of life in an 88 years old lady. But
For
it
mild,
means a lot for a young active patient.
But then, even if you go to lower rates, still, as you suggest in the slide, so it's infrequent to have root enlargement by surgical.
Do you have
approach.
surgeons that do root enlargement in Greece? In Israel, it's not.
We have
not
Dr.
common.
Kontrafouris, who's a surgeon in our hospital. Yes. You can have the microphone. It's over there.
So it's not so we don't make so often enlargement, but in the last years we tried to put valves more than 29 just to not have the problems of the small aortic annulus in the future. So the thing is to make a root more than 21 just to have better result. And
So I can tell you what is my practice for patients with small anatomy. Usually, if they are going to TAVI, then they will have self-expandable supraannular device as high as I possibly be, and I will predilate quite aggressively in order to gain as much room as I can, and usually I post-dilate as well. I'll show you some data regarding to implantation depth in a second, but why supraannularity matters? This is from one of our bench testing for valve-in-valve conditions from maybe 15 years ago already. On the left, this is implantation in high position, and on the right, this is in low position. So the difference will cause lack of supraannularity when you're on the right and with supraannularity on the left. So obviously, we would prefer in systole or diastole to be on the case on the left. It opens better. The EOA is much better, right, on the left side. And when the leaflets close, they have less pinwheeling. The valve looks more healthy when it is supraannular. So for me, from this bench testing that we performed and published like 15 years ago, it was quite clear. This is the way to go. We need the leaflets to be a bit outside of the problematic area of the small annulus. So fortunately, we have big, large, randomized study comparing two strategies of TAVR in small annuli. So total of around 700 patients, the SMART study, big publications already in New England and other publications already, 3 years follow-up were gathered. Basically, in 3 years, it's too early to say about mortality or stroke or rehospitalizations. But when we look, even if I take out the blue column here of the Evolut arm, it was compared to SAPIEN procedures. When we look at the results of those in blue, to say more than 50% bioprosthetic valve dysfunction in 3 years, this is a problem. Having too many patients, it's not like a partial or like a minority. The majority will have bioprosthetic valve dysfunction. So this is a big concern to me, and in my practice, I think it says something. It says something about what to do with these patients. So there are other signals that are concerning with when we compare between the groups. Endocarditis. I never seen like a difference in endocarditis between platforms. We have more endocarditis when we use SAPIEN in small annuli. Does it make sense, guys? Like, could it be that in some way endocarditis could be more? These patients will be more prone for that?
Maybe, I don't know. So maybe we have in a smaller Edwards platforms, we get to see more health, at least in our experience. So we are more, let's say, we order more frequently CTs for DCTs to investigate the health. So I think maybe it's a common mechanism. It's like the turbulence that you have the increased resolution that we have in a small valve, in a small platform, then you get to have possibly, I don't know, more, these people might be more prone to
There
endocarditis.
is something in the flow, you're saying. And in general, endocarditis is one of the worst adverse events that can happen to, especially to those patients, fragile patients that have TAVR. They are not good for open heart surgery, right? And then we have a patient with an infection on the valve, and you're not sure what to do with that patient. Medical treatment, and sometimes medical treatment is not enough. It could be a big problem, endocarditis, and we see that it's more common in one of these platforms. Also, clinical valve thrombosis, 1.3% for Evolut versus almost 6% for the Sapien arm. 6% clinical valve thrombosis. It says something. We do not see the difference in reintervention between the groups yet, but I cannot imagine that this is only 3 years, 5 years, 8 years, that it will be translated to something. Here you can see some more data on prosthetic valve thrombosis comparing the groups. When it happened, it usually happens in the first year and a half after. So we talked about being small as a spectrum, right? And there is small and there is very small. It seems that those with area below 386 are especially prone for worse gradients, lower EOA, worse DVI. So these patients do not do as well. Here is some data on prosthesis patient mismatch for the two groups. Basically, this is a group that is prone for PPM. For the Evolut arm, it's around 10%, and for the Sapien, moderate or severe PPM in a third of these cases. So what happens to patients that have severe PPM? We see that eventually, those with Sapiens that have severe PPM were associated with more mortality, cardiovascular and total mortality. So PPM is not a good thing to have. Prosthesis patient mismatch is something that it's not a myth. It's something that we need to identify the patients that are prone for it and prevent it as much as we can. So in a related thing, I present to you something that we published only 2 weeks ago, JACC intervention, maybe more, 3 weeks ago. PCR presentation first time. For a long time, I was really obsessed on data related to implantation depth. You know that over the years, valve-in-valve conditions, that was more easier to understand what is the impact of implantation depth because the gradients after valve-in-valve are not as good, right? But could we see the results of implantation depth in the general population, in native TAVI, and to have a large group, large registry that will compare it, maybe to have a core lab that will evaluate the implantation depth? Fortunately, we have the Optimize Pro registry. Optimize Pro is a prospective registry of Evolut procedures that was performed. They were performed in the United States and also in Europe. Greece was part of Optimize study. Were you part of the Optimize?
We were not in the Optimized Pro.
Well, but it's still a big registry, a total of 653 patients. Eventually, we decided to stratify these cases according to implantation depth. Up to 1 millimeter in depth, 1 to 3, 3 to 5, deeper than 5. 4 groups. And this is, believe it or not, the largest to date implantation depth evaluation in TAVR. We are 2026, it's like 20-something years after the beginning of TAVR. This is the first big paper on implantation depth in native TAVR. So let's compare the groups. Baseline characteristics, well, average age is close to 80, same patients. Gender, did you know, Arik Finkelstein, that female patients on average were implanted higher than male patients? I didn't know.
I swear to God that I will tell you yes. You know why? Because smaller valves are much easier to control and to implant in high.
So this is exactly what we thought, and it's not correct.
Really?
Yeah. We thought that 34s.
Couldn't you say, just whisper to my ear, not that everybody will hear?
We thought male patients, 34 valves, 34s are more complex to deploy, implanted lower, and this is causing the difference, but you'll see in a second, it's not the story. For some reason that we do not know, maybe there is a smart person here in the room, female patients are implanted higher, clearly higher than male patients, could be related to calcification of the valve.
No.
Maybe interaction with a physician, male physician, female gender.
No, so we thought correct that female implanted higher, but not because of the reason, not because it's a smaller valve.
Not because of the size of the device.
So what's the reason for that?
We don't know. Maybe calcification. You know, this is new data. History of RBBB did not differ between the groups, 5 to 7% risk for pacemaker. One of the things that we wanted to know is whether there is a difference. Well, we have now core-lab evaluation of implantation depth. Now we had a beautiful live case, and we said, oh, you're 2, you're 4, you're 6. When you say that you're 4, are you actually 4? Or is it like psychology thing? Psychology is involved in these evaluations, right?
Yes, as everything in life, of course. So you are burdened by your previous decisions. And of course, the things that you have experienced.
What would you imagine if the difference between the core lab and what operators suggested, the depth? Higher, lower?
Well, I have worked in the past in the core lab, and you know, it's like VAR in football. It depends on where you draw the line. So this is a contemporary knowledge. So I'm not sure. I'm not sure that, of course, this is independent core lab. You have
people many times think that they are better than they are. Let's say it like that. But basically what we saw is that the core lab suggested that the median depth was 4, and operators suggested that they are 2-3 millimeters higher.
Yeah.
In a very systematic fashion, by the way. For the left cusp or for the non, it says a lot of things, by the way. It says that if you think that you are in a certain depth, have another person in the room suggest what is the depth, because you sometimes try to make it brighter than it is. This is something that is, for me, clearly important. Let's look at gender, because gender interacts with a lot of things in this analysis. Gender, we saw that female patients are implanted higher. Gender and THV size. 23, 26, 29, 34. In purple, female patients, in green, male patients. Not many 23 natives, it's not India here, right? Only 7 patients, we can even ignore it. All of them are female patients. 26 is a female patient device, almost at all. 34 is a male patient device, almost all of them. 29 is split. Right? This is in general that we'll understand which valve is what. So when we compare female and male patients, there is some difference in implantation depth. For some reason, the 34s, the notorious 34s that are difficult to implant and complex and risky, in that study were not implanted lower than, let's say, 29s. They were not. It's implantation depth is about the same. 26 were implanted slightly higher, but it interacts a bit with the female gender. But we can say in general, 34s are not implanted. It's not the 34 to blame for the gender theory here, showing that there is a difference. Let's look at procedural outcomes. So now we have outcomes according to implantation depth. Median length of stay, it's much shorter for those that implanted higher. Resheath and recapture, a clear trend, better if you implant higher. Pre-implant valvuloplasty, we don't see a statistically significant difference, but there is a clear trend. Those that were implanted higher had pre-deal in 63.6%. Those that were implanted the deepest, 52%. It's something. And post-implant dilation, by the way, worst in those that are implanted lower, 16.8, and lowest in those that are implanted higher. One of the things that is important to understand is whether there is some risk associated with high implantations, right? Pop-outs, whether there will need to be another valve implanted, but have a look at the results. Pop-outs, valve migration, embolization, several valves to be implanted. This is very rare. This is a rare phenomenon to need several valves in TAVI. It happens, but it's rare. Valve migration, pop-out. This is right in your life case. We fear that maybe if we take the first position, the valve will jump out. But this is like Arik said during the case, take the first position. It's quite good already. Here are 1 year clinical outcomes. At least in 1 year, we don't see difference in mortality or stroke or intervention, which is very, very rare. But let's have a look at the next slide. 1 year pacemaker result according to implantation depth. Clearly, there will be a difference, better for high implantation, right, Arik?
Yeah, but not as much as we thought.
Not as much?
Not as much as we thought.
What do you think would be the... We're going to see in a second 4 columns here. It's around, in your center, you said 12%, 11%
Yeah, it's
pacemaker
11%.
rate, 1 year. How would it look like? 4 columns now. What's your guess? Around.
Now the contemporary practice, you mean?
Up to 1 millimeter in depth, 1 to 3, 3 to 5, deeper than 5. Clearly, there is going to be a trend in favor for high implantation, but
Yes,
to
of
what
course.
degree?
But did we take into account the measurement, the length of the membrane septum or not? We don't know.
Not in that analysis. I'll make it simpler.
So it's not corrected, it's just the depth.
Let's look only on the column that will be on the left in a second.
Okay, let's see.
Up to 1 millimeter in depth. If I'll take Evolut and put it at 0, what is the risk of pacemaker in 1 year? In that group, 88 patients. It's not like
6%.
First,
Yeah,
you didn't read the
around
paper.
5,
It says a lot that you
It's
didn't
around
read the
5,
paper, but it's okay.
It's around what, 5%? Yeah.
So the risk was 2.3%. 2.3 for a large group of cases. 88 patients, 1 year follow-up. Some of them had RBBB. What does it say? It's a big contributor to pacemaker implantations. And it's no-brainer, right? Where we put the device impacts dramatically the risk of pacemakers. So the fact that we can reach 2.3% pacemakers in 1 year in a large group, just by having that approach of extremely high implantation and without safety events, to me it says a lot. Let's look at something else now. Let's look at how valves function. Echocardiographic outcome composite. We looked at optimal valve function. And the definition is a discharge. Non or trace PVR, this guy doesn't like mild PVL, so no PVL, no mild PVL here, non or trace. Mean gradient, single digit or 10, up to 10, and no prosthesis patient mismatch. And now the 4 famous columns according to implantation depth in male patients. There is a clear trend for better valve function when you implant very high. It's clear. Valves like you don't see surgical valves implanted in the LVOT, right? So why should we put the TAVI devices deep in the LVOT? So this is irrespective of pacemakers. So for male patients, we see better echocardiographic outcomes. For some reason, this is for female patients. I have no idea. Maybe Chaim, afterwards, you'll give your theory. Female patients implanted higher and their echo results is not as sensitive for higher implantation. I don't know. NYHA class 1 at 1 year, there is like a trend for better NYHA also for those that are implanted higher. And in general, well, no need to read the summary. It's clear that with the high implantation, we were able to get a lot of benefits and still in short-term period, we don't see any price for it. Where do you take these results?
You know, Danny, I love your talks. No, I'm serious. I love your talks. I think it's fascinating, but I hate to be a fun spoiler here. This is not randomized. Now, you know what? I'm just thinking of my patients and ask my team. Before I start to implant the valve, I stop. You can ask him. And I'm saying, look, she's 88. We took a valve which is a little bit oversized or a little bit undersized. Her basic ECG is not LBBB, but she is close to LBBB. So we're going to implant here I, or this is a patient with this, this, and this. We don't want to be greedy. We're going to implant it 4 millimeters. So to take this whole group as annulus and say these with high implantation, yeah, this was high implantation on purpose because a priority I had a reason to implant it high. So just to take the numbers.
There is a bias, you say.
Definitely, because it's not randomized. That's what I'm trying to say. It's a wonderful job. Don't misunderstand me. But I don't take it as a Bible. Nevertheless, again, this has a price. And the price is that the holy grail that we used to see with high implantation is not a holy grail anymore, because next time it's going to be much more difficult
The
to put
redo
a
TAV.
TAVI in TAVI.
Yeah.
So it's another reason in a lady like this, she's young, I'm expecting a TAVI in the future. On purpose, I say, hey guys, let's put it deeper. So I think it's wonderful data. I think we should use it, but I think we should use it with caution.
So do you have a sense that it's not like a refined decision to use this algorithm 1, 2, 3, 4 millimeter inside? So we are going to show later, hopefully time permitting, a live in a box with an Evolut valve that we were happy that we used the FIOPS software. So this can guide you maybe to have a better valve procedure. So maybe you can select the 26 with mid plantation instead of 23 with a high plantation. And so maybe there are things that can evolve, down the line. So yes, but we have to. I think it's not for everyone. You have a high plantation. We should aim high plantation in order to reduce pacemaker rate, but there are other factors that play: the baseline EKG, the membranous septum, the elongation of the calcification in the LVOT, many things, right?
For sure. It means that we need to be minded, at least, to that topic. And if in the past we're going to say, oh, the valve sits well, it's not malpositioned, it's not too high, it's not too low. Now, in 2026 and forward, we need to think exactly where we put our valves, because especially when we know that many of our patients will have these valves for many years. It's not like 20 years ago, 15 years ago, that it was for 2-3 years. These valves are going to stay. And redo TAV is a concern, and this is an introduction to the next presentation. So we put the second one. It's going to be on redo TAV. So I'm going to escape you, or what should I do?
Okay. The redo TAVI then.
So obviously, redo TAVI is growing dramatically. Arik, you have more cases coming over like this year than in previous years. TAVI in failed TAVI.
It makes me a deja vu of the stent restenosis,
Yeah.
but so much different than just stent restenosis.
But yes, it's not easy to get away with it. Like.
How is it in Greece, redo TAVI?
It's very rare still. So out of 2,300 cases that we have done so far. I think it's 7 or 8 TAV in TAV. So very, very rare for the time being, but we project that these people will start to come back because I think that the longevity of the patients now has increased because they are younger patients, because in the old time we were treating patients that with a mean age of 86, now we have 81 still, higher age patients, but we will get to see more often these patients. But most of the times, I think it's the index procedure. It's not, there is some problem with the index procedure. There is some valve that hasn't been expanded properly. There is not symmetrical expansion of the valve. It's some issue, probably technical.
I suspect from the graph that you showed during your great presentation, like earlier today, that you had like not a lot of cases in the first couple of years,
Yes.
but now you're doing 400 cases a year. And last couple of years, 300s.
Yes.
That in 5-10 years, you're going to see dozens of TAV failures coming to your center that will require treatment, not 2 or 3 or 5. It's going to be like a significant part of the practice. This is a curve from analysis that we did with several really bright engineers that try to understand what will be the magnitude of valve-in-valves in the future in the United States. And in the x-axis, these are years. In green, you see the TAV in SAV cases. These are failed surgical valves. In red, the TVT registry data, which is quite overlapping. And what is that blue curve? The blue curve is the prediction for TAV in TAV. It's going to be, according to our prediction, we published it in Structural Heart 2 years ago, 2 years ago. You can read about all the assumptions that led to that graph. There are many assumptions. But in like 5 years, we're going to see more TAV in TAV than TAV in SAV. For many reasons. We have less surgical biological valves being implanted. TAVI is dramatically increasing, especially in the US, 120,000 a year or something like that. So in 2035, in a decade, 3/4 of valve-in-valves are going to be TAV in TAV, and that number of cases of valve-in-valve will be 5 times of what we see today. Where do you see?
What I miss here is the numbers of native TAVR in the same year.
Sure, it will grow.
No,
it will not grow as much.
This is going to be 10% of all TAVI or 20%? Because at the beginning of TENS, like at least 25% of our procedures were in-stent restenosis. So I'm wondering what the percentage of these 42K going to be out of all TAVR procedure in the States?
It's an interesting question. We know that valve-in-valve, which is TAV in SAV almost exclusively until recent years, is around 7% of conventional practice. Which centers will do more valve-in-valves will be big surgical centers that have like a very strong a program of surgical AVR over the years, many biological valves. These programs, let's say in Beilinson in Israel, in Tel HaShomer, in Ichilov, big centers. I'm sure that in your center as well, you have many valve-in-valves, I'm sure, that have big surgical program, they will have TAV in SAV. Centers that are doing 400 TAVIs a year nowadays, in 5, especially in those that are around the age of 70 and a bit, maybe sometimes less than 70. In 10 years, they will be bombarded by TAV in TAVs. It is quite clear. It is quite clear. And why is it important? Because TAV in TAV, and I'm working on the valve-in-valve field for many years, TAV in TAV is a bit different. Like Arik said, it's a bit different because in the TAVI landscape, when we look at potential adverse events, let's look at different columns here. We have conventional TAVI on the left. We have TAVI in stented surgical valves, which is the TAVI in SAV, the common TAVI in SAV. We have TAVI in stentless surgical valves, and we have the TAVI in TAVs, which is also a group of cases, right? We have failed the Navitors, we have failed the Evolut, we have failed Sapiens. It could be a different case. But we are not concerned about malposition, right? But we are concerned about coronary obstruction significantly with TAV in TAVs, especially with certain valves. We are concerned about coronary access in some way, and we are concerned about residual stenosis. So these are the things that come to mind when we think about TAV in TAV. Residual stenosis and maybe the durability of our cases. Now it's a second case, and we are losing room with each valve, Russian doll phenomenon, and the risk for coronary obstruction. So the priorities for TAV in TAV obviously would be first to identify prevention, to identify coronary obstruction risk in our case, to know whether the case is at risk for coronary obstruction, to optimize hemodynamics, to maintain coronary access, to prolong the valve durability. These should be the priorities. So I'm not going to dwell on that for too long, but it is clear we have now a lot of nomenclature on how to assess the risk for coronary obstruction. If historically we didn't understand clearly the mechanism, it's quite clear. It's a deflection of the previous valve leaflets towards the coronary ostium. And we have the neoskirt plane, which is the top part of the deflection of the previous leaflets, the neoskirt plane. And we have the coronary risk plane, which is basically the plane where the coronaries emerge. Each coronary has its own coronary risk plane. And we need to understand the relationship, whether the neoskirt will go or not go above the coronary risk plane. I'll go to a much older definition of risk of coronary obstruction. This is a vivid root classification because it says a lot about relationship between deflected leaflets and coronaries. Type 1. We have a surgical valve. But the leaflets of this surgical valve will deflect below the coronary ostium. And therefore, there is no risk for coronary obstruction, conventional coronary obstruction in this case. So in this case, we do not care about the coronary height or the sinus width or the VTC. We don't measure VTC. This is a case not at risk for coronary obstruction. Type 2, the deflection of the leaflet will go above the coronary ostium, or the neoskirt plane is going above the coronary risk plane. And in these cases, we need to understand what will be the residual gap between the deflected leaflet and the coronary ostium. We measure VTC. VTC is a parameter that we defined in Vancouver like 15 years ago, and it became the gold standard to assess for coronary obstruction risk, and we have a strong cutoff of 4 millimeter. This is approximately the size of a small left main, 4 millimeters. We want the inflow to the left main, also to the RCA, to be around at least 4 millimeters. And we have obviously the type 3. Now the neoskirt plane will not only go above the level of the coronary ostium, it goes above the level of the STJ. Unfortunately, sometimes after TAVI, we see cases where the leaflets will go above the level of the STJ. And we need not only to understand the residual gap at the level of the coronary, but also the residual gap at the level of the STJ, because potentially there could be what we call sinus sequestration. We can do full blockage of the inflow to the sinuses, and obviously coronary obstruction is a nasty complication. It can lead to patient death. So we need to prevent it as much as we can. So obviously here we have two Sapiens. The one on the left, we don't need to measure any VTC or anything. This is not a case at risk for coronary obstruction. The case on the right is the opposite, obviously. Another thing that is very, very different when we talk about TAV in TAVs is the understanding that an implanted valve can have many, many different morphologies. So if you have a surgical valve, let's say a mosaic 23 that is implanted, we know what is mosaic 23. We know the height of mosaic 23, we know the diameter of it, it's all described, it's clear. But when we have, let's say, an implanted sapien 23, the diameter of that sapien 23 is not 23. It's in many times, it would be 20 or 20.5. Maybe this is why it failed originally. So we need to understand clearly the anatomy of that failed TAVI device, where in surgical valves it's not as important. So here we have a 23 valve that is failing 4 years after. The diameter is 20.6, and obviously in these type of cases we need to prepare the valve to another valve. Like Arik suggested, you have in-stent restenosis of a bare metal stent. We cannot just say, oh, okay, let's put now the Cypher device and now we are okay with our drug-eluting stent. No, we need to prepare the first failing valve well before we put the second valve. It's clear. This is why the CTs are much more important than they are for TAV in some cases. When we talk about these combinations, so we have a lot of TAVI devices, right? How many TAVI devices do you have in Greece nowadays available?
I think, well, in our hospital we use 5 for the time
5.
being. So
In Israel we have 5 also.
yeah, but there's an additional we don't use as well. It's the two that we don't use for the time being. It's Hydra and Microport device, but we use, of course, 75% Medtronic, and the rest will be Edwards, Abbott, Allegra, and Myval, of course.
So we can split these devices into 2 in general, to those that are long and those that are short. It's a good stratification of cases. And in many cases, the short are better treated with long, and the long are better treated with short. But you can do other combinations as well. Basically, tall in tall, short in short, short in tall, tall in short are all the different combinations. But we can say, at least for failed short devices, we have data, enough data to suggest that doing Evolut in these short devices will get better hemodynamics than putting another sapien. Let's say you have a failed sapien. Easily you can put another sapien there, but will it start another process of degeneration early, and the hemodynamics are not as good. So tall in short are better than short in short. This is from the different combinations we can say. So I'll summarize with regard to TAV in TAV. First, we need to ensure that the indication is there. So paravalvular leakage of a TAVI device is not, maybe it's not for TAV in TAV, maybe it's for post-dilation. HALT is maybe for anticoagulation. Endocarditis is maybe for endocarditis treatment, right? And so you need to understand why you do the case. You need to learn as much as you can from the index TAVI procedure. Maybe they had an issue with the legs. In a second, you're going to do the same case. So you need to understand what happened in the original case to obtain as much index procedure information, including the pre-index TAVI CT if you can, if it was done in a center that you can have the CT. CT analysis is crucial. You need to define the risk of coronary obstruction in that particular case to optimize second TAVI device size, type, and position. Pre and post deal considerations. I'm very aggressive in pre and post dealing in these cases with the non-compliant balloons, and obviously to aim as much as you can for commissural alignment that will allow for better coronary access later on. So with that, I can show a case, or we can.
Yes, I think we can have a case, and then we should conclude the
Okay.
satellite symposium.
Okay, fantastic. So a 69-year-old. Many of the failed TAVI devices patients are those that are implanted in a younger age. It's true. Younger people degenerate faster. It is what it is. A 69-year-old lady, many comorbidities, got a Sapien 323 around 6-7 years before. Now she's coming with severe aortic stenosis. Mean gradient is extreme. She was considered, although she's young, not for
But she had TAVR when she was 60.
early 60s.
Early 60s because of the cholangiocarcinoma? What?
To be honest, I have no idea. I don't. I was not there. I assume, but yeah, I assume. Mean gradient extremely elevated, and this is what we see. Some distortion in the CT, but these are common CTs that we get for these cases. Coronary heights are 11.4 and 15.9. We see some panus on the leaflets. This is not halt. And when you measure like the distance VTC assessment, for the right it's 2.9, for the left it's 4.4, and the VT-STJ, like the inflow to the sinus, 1.3 and 3.5. And I'll go forward a bit more. Here you can see a long axis video on the right, showing the relationship. So there is a bit of distortion, obviously. And this is the short axis going up and down. We see a lot of calcification on the valve leaflets. See the left main coming here and disappears. So what would you do? 23 Sapien 3 requires treatment. The CT is not very clear, but it seems that the distance, the sinuses are effaced.
Yes.
The coronaries may or may not come. They come below the top of the frame, but maybe not below the top of the deflected leaflets. What would you do? Repeat CT is an option. Let's say that.
I don't know the patient, but why won't she go to surgery? I mean, she's
Legitimate.
69 years old,
Yeah.
right? She's got all the reason to have another valve in her career. So this is going to be the third one. And, you don't build on future technologies. And if we're not going to have an outstanding revolution regarding leaflet modification until then, it means that she might need a surgery of 2 explantation at the age of 78 instead of having one explant at the age of 69.
Yeah,
But I don't know the patient.
It's a legitimate consideration, and open heart surgery should come as a good option for her, and it's a discussion. It's something that should be.
And,
What do you say, Chaim?
So you sent surgery, yeah? Yes, and of course with this STJ, it's very the height is not is low, so I think that there's a great danger of having the coronaries obliterated. So
By the way, Chaim, I don't believe with the patient doesn't want.
yeah.
If you truly want, the patient will go to what you will tell him at the end. I mean, there are some very, very rare exclusions. And look, I'm a cowboy, okay? I'm doing TAVR for people that I shouldn't have done. I'm not a Maria. But I think that when I see a patient like this, I don't know her. Maybe she was too risky, etc. But if I see a patient like this and I think that he should go to surgery, and nobody wants surgery, you can convince him.
Well, I don't know about that. Dr. Mariano, Erika, you have.
ourselves, and we can speak about the patient, the caregivers, the other one. It's a complex decision, the possibility of such a
Stuff.
Yeah. So,
it's a very complex
yeah.
discussion.
Danny, do you think this consideration, these things were considered in the index procedure, so
Yeah.
was informed properly?
Yeah,
and,
for sure. The oncological state was not very clear, although it was many years ago, and she was a frail patient. She's not a conventional 69, and we went ahead
Yes,
and did the
so-
TAVI after several discussions within the team.
She gained some years of quality life, so now you have to do the hard part, yes?
So one of the reasons that I brought this case is because it has like a message, irrespective of like the challenge and the risks associated with this type of cases, is the fact that this case looks at risk for coronary obstruction, right? It does look at risk for coronary obstruction, though the CT is not perfect. Now let's have a look at the images from the actual case. So she started with cath lab evaluation for coronary risk, which is a bit ignored in 2026. Like we consider like CT as the best modality to assess for these risks, but actually, when you do selective injections and look carefully on the relationship between valves and the coronaries, you can understand that sometimes you think that there is elevated risk, but it's not there. So part of the assessment for risk, especially in borderline conditions, is cath lab assessment. And although I love leaflet modification and I do it a lot, this is not a case for leaflet modification, not for the left and not for the right. So that patient had like a conventional Evolut procedure. For some reason, I didn't do pre-deal, or maybe I did and didn't present it here. Usually I do pre-deal in these cases. Evolut, high implantation, post-deal aggressively, because I know that the risk for coronary obstruction is not there, and she did well. Okay, so TAVI in TAV, the future, part of the future of TAVI in general. Thank you so much.
Thank you, Danny. Amazing talk, and we learned so much. Thank you for that. And some of the things that you suggested and your question will be answered later on in this conference. So we have some leftovers from the previous cases, from the previous sessions. So we have Dr.